is ADILAH LIYANA binti ADLI.
Hi, my name is AISYAH.
Hi, my name is ARZIAH.
Assalamualaikum. Hi, my name is NURHANI.
Hi, good day everyone. My name is VILOSHENY NAVARATNAM.
We are from Group 4 and this is our poster.
Hi everyone. Okay, the first thing first, the introduction. Let's talk about what is obesity. Does everyone knows what is obesity is all about? Yes, it is correct. According to the World Health Organization, the WHO, obesity or overweight are defined as excessive fat accumulation that presents in body that can risk to our health. How do you want to define someone? How do you want to tell that someone has obesity or overweight? Okay, let's say if you calculate the BMI index, if over 25, it's considered as an overweight, and over 30 is considered obese. So this obesity issue has been growing into an epidemic for so long time, widely prevalent to the whole world, and in 2016 around 650 million adults are obese, and in 2020 research 54.2% of Malaysia's adult population is overweight or obesity. Okay, now let's talk about the clinical features that are presented in the case study. So in this case, there are around 5 clinical features that we are found in our journal, which is the first one, adenosis. Second one is the loss of her teeth, illness, persistent preoccupation, and poor body image. Okay, so let's talk about the adenosis. What is the adenosis? Adenosis is eating disorder, not otherwise specified. Maureen was a 39 years old woman with a 15 years history of yo-yo dieting with daily self-induced vomiting. Okay, in this case study, we found that the clinical features of her being obese is, the first is adenosis. She independently assessed at pre-treatment by her psychiatric register and diagnosed with adenosis, which is eating disorder and not otherwise specified. So this is the meaning of adenosis in DSM-5 diagnosis system. Okay, so the second one is she lost her teeth. She had lost 7 teeth due to vomiting. No evidence of shedding of binging, no use of diet pills, over exercise, and laxative abuse. Okay, so we go to the next one is illness. She has been diagnosed with borderline thyroid, which is her means global is of EDEQ score questionnaire, around 17 questions, and pre-therapy was 4.493, which is also scored as a higher on all of the subscales. Okay, next one is she's having persistent preoccupation, meaning that she has this eating and irresistible craving for food. Are attempts, constant attempts to restrict food intake, periods of overeating, and also she vomiting at least once a day, which is the worst scenario. Okay, so the last one, we found that Maureen has poor body image, which is the independent of fluctuations in her weight, which is in particular discussed in to her abdomen, the back, and also the legs. There is no overt body and weight shaking behavior. That's all for me. Thank you.
Today I would like to present the relevant scenes on how the extent her condition affect her daily functioning life. As you can see at the screen, the first point is often ridiculed by peers at school. She was often ridiculed by peers because of her large body size and taste. Some of her friends also back away from her, and because of that, she considers herself as big and slow. She also avoids doing physical education class, and she will do it every time she had a class schedule, and made her mother believe that she was sick and could not go to the school. The second point is blockage and vomiting. She used to punish herself for eating what others would eat considered normal food. She consistently skips meal, and when she's stressed, will often hinder herself for a day for more at a time. Another point is high level of internalized shame. It happens when she feels fat and big, and because of that, she feels herself not a good person and no one wanted to be friends with her because of her physical appearance. For example, when she was 19, she worked in factory. She don't want to take on any position that involve exposure to public. The last point is the onset of myalgic encephalomyelitis worsen. It worsened her perception that her body is out of control and further reduce the chance of physical exercise and weight reduction. It occurs after having the first child, causing the fatigue with joint pains. She described the feeling of loneliness and depression. In this scene, we can see Marine always feel the horrible because of her condition as a obesity.
Hi, I'm going to explain why Marine has an eating disorder. Marine is a case study diagnosed with ADNOS, which is eating disorder, not otherwise specific. Why is it not specific though? Because Marine has a symptom in each of other classes in eating disorder. So let's take a look one by one what causes it.
First of all, Marine live in a rural area outside of Aberdeen. So obviously, she have a hard time to have an access to a specialist. So when her doctor suggested her to do a video therapy treatment, Marine said that she probably gave up if she have to travel to do a face-to-face appointment. Secondly, one of the reasons why she started to develop this disorder when she was a kid, Marine and her sibling is expected to finish all of the food in their plate, and since most of her family is overweight, the portion of the food in their plate is quite a lot. She started to feel different from her peers because of her size body, and also she get derided in school. And thirdly is after her second marriage, she underwent a surgery called a pronectomy because of her eating disorder, and sadly it was unsuccessful, and because of that she suspected hernia. It causes her to miss her appointment for her video therapy appointment. Okay, the next one is Marine also has a complex relationship with food from a young age. When she developed a sense of feeling different from her peers, she started to feel wasn't good enough, and ended with her learning that eating is her comfort. When she did that, it led her to punishing herself by vomiting, restricting herself from eating, and also constantly scanning her body. Lastly, the onset of myalgic encephalomyelitis make her body become much more worse and reduce her opportunities to exercise and weight loss.
The action taken. Physiotherapy was offered to Marine before her first treatment. Due to her circumstance that she had difficulty in transportation and childcare logistics, causing her to be unable to attend regular face-to-face appointment. The physiotherapy what to expect information sheet was sent with the first appointment letter to her. The treatment through a video conferencing system took place at her local community hospital, and a clinical psychologist trained at the doctoral level conducted sessions from a 10-bed video conferencing system based at the Eating Disorder Service at Royal Cornhill Hospital, Aberdeen. The screen was preset at both ends, so the view was of the torso and head. However, the therapist or client could change this view anytime by remote control. Marine was advised to attend her GP and dentist for regular physical checkup throughout the treatment. The schema mode therapeutic model was chosen to address the long-standing nature of her eating difficulties and chronic low self-esteem dating back to childhood. Initial data suggests that this model may be highly relevant to the eating disorder population and that schema may be linked with specific eating disorder behaviors. For the first 2 weeks, Marin learned to self-monitor her eating pattern and link this with emotional triggers. Regular meal and snack were slowly reintroduced and catastrophic cognitive in relation to weight gain were challenged. Behavior strategies were used to plan means and delay and eventually replace vomiting. More dialogue and experimental chair work technique were used to challenge her extreme pattern of self-criticism, self-shaming, and long-standing avoidant coping strategy. Imaginary techniques were used to rescript early memories of being blamed, teased, and to heal the underlying emotion damage caused by this experience. As a result, Marin gradually learned to value herself and relate to herself from a healthier, compassionate position. Her eating pattern normalized as she began to conceptualize food as a requirement rather than something sinful that she should be able to resist. Schema flashcards were used to challenge self-criticism, alert her to use her new coping strategy, and affirm her inherent self-worth. As a result, she began to examine herself from the accurate perspective of others rather than to her social undesirability schema.
Good day everyone, my name is NAVARATNAM. So today I'm going to explain the conclusion part. So for some people, which is normal people, eating is normal, but people with eating disorders, they may have the different thought of eating, which is they may think that eating is a sin. So eating disorder is more than a food problem. They involve complex mental health conditions that often require the intervention of medical and psychological experts to help them slowly recover from this disorder. There are so many aspects that contribute to this disorder. Eating disorder affects almost 5% of the population, often developing in adolescence and also young adulthood. Cure for eating disorders consists of in eating healthy with medical care and psychological treatment. Ambivalence towards the treatment or help from someone professional or denying having an eating disorder is not something uncommon. With proper medication and therapy, someone with this disorder can feel normal again with their body, lifestyle, and also food. Helping people with any disorders has always become a priority for professionals, but there are always going to be some hindrance to doing so. A prominent example that always happens everywhere is a budget deficit and access to professional help. Later we know the patient is giving up. So that's all from us. Thank you very much.